Hello everyone, welcome to the very first video of this channel. And the first topic of discussion happens to be malaria, because it's 25th of April today, World Malaria Day. And in India, it accounts for around 1.3 to 2 million cases per year, which are obviously more during the rainy season. And globally, around half of the global population is at the risk of contracting malaria. And in 2021, almost 95% of the cases came solely from the African region. It is a vector-borne disease caused by the parasite protozoa, that is Plasmodium, protozoal category of parasite. It is caused by four subtypes: Plasmodium vivax, Falciparum, Malaria, and oval. Falciparum being the most common and the only even responsible for causing death in the malaria. Vivax and oval are responsible for causing relapse, and the vector, as it is a vector-borne disease, the vector responsible is female Anopheles mosquito, which can be identified by the black spots at the margins of its wings. This there happens to be a few previous year questions in AIIMS regarding the differences between relapse and recrudescence. Relapse is nothing but a recurrence of the infective episode after the completion of treatment, and it is due to the dormant forms, also known as the hypnozoites. Relapse occur with Plasmodium vivax and Plasmodium oval, whereas recrudescence is nothing but resistance to the drugs, which can be due to incomplete course of the treatment or the non-effective drugs for that species. Regarding the pathophysiology and the life cycle of the malarial parasite, the infective form is a sporozoid, and the life cycle consists of two phases: sporogony and schizogony. Sporogony is a sexual phase which takes place inside the mosquito, and schizogony is a asexual phase which takes place in man, having two parts: exoerythrocytic cycle and the erythrocytic cycle. By the name itself, it implies the first one takes place outside the RBC, that is in the liver cells, and the next one in the RBCs. As we all know, the infective form of it is sporozoid, which after the bite of the mosquito gets injected into the human body, enters into the hepatic cells, where they multiply to form the merozoites, which are released from the hepatic cells to enter the RBC, which multiply to form the sporozoites. A few of them get converted to schizones to complete the cycle, and a few of them get converted to micro and macro gametocytes, which after the mosquito bite are taken up to enter the mosquito, where the sexual cycle begins, where it is first converted to micro and the macro gamete, which fuse to form the zygote, followed by ookinete and the oocyst, and hence the cycle continues. Regarding the clinical features of the malaria, the incubation period of the Plasmodium falciparum species is on an average 12 days, which is the shortest among the other species. Initially, the patient presents with very non-specific complaints, including fever, malaise, vomiting, headache, but classically, which a lot of patients present with, but not necessary it should be present in all the patients. It is the intermittent fever with chills and rigors. Fever usually follows a pattern in accordance with the Plasmodium species causing the infection, where it is a tertian pattern fever occurring once in 3 days in infection with Plasmodium vivax and Plasmodium ovale. A quartan type once in 4 days in accordance with Plasmodium malaria, and it occurs daily in cases of Plasmodium falciparum. In cases of children, febrile convulsions has to be watched out. On examination, we will find mild anemia and jaundice due to the destruction of the RBCs, and mild splenomegaly may also be present if the case is presenting from an endemic area, indicating that it could be a case of repeated infections. Regarding the investigation of malaria, the most common investigation which we happen to do in government setups is a PS for MP, peripheral smear for the malarial parasite, where thin and thick smears are made with Gemsa stain. There is one question which has been asked about the cytoadherence property of Plasmodium falciparum, and what is that property of Plasmodium falciparum? The RBCs which are infected by the Plasmodium falciparum, they produce these knobs which then adhere to the endothelium of the blood vessels. As a result, the schizones and the late trophozoites are not visible in the peripheral smear. Before going to the treatment, let's have a brief look regarding the prevention from PSM point of view. The Gambusia fish, also known as the mosquito fish, which feeds over the larvae of these mosquitoes, and use of the mosquito repellents and mosquito nets, typical size being 1.2 mm, the whole size, and also using chemoprophylaxis if someone is planning to visit an endemic area. Chloroquine 500 mg or mefloquine 250 mg can be used once per week. It is used in this way that it has to be started 1 week prior to the visit and should be continued for 4 weeks after returning from the visit. Treatment of malaria is another topic from pharmacology point of view, and questions have been asked from that as well, but we'll have a brief look regarding the treatment for the completion, for the sake of completion of the topic. I'll be dividing into 3 headings: chloroquine sensitive, chloroquine resistant, and severe malaria. For sensitive, as the name implies, we will use chloroquine along with it primaquine in order to prevent relapse, which is caused by Plasmodium vivax and Plasmodium ovale. But primaquine is contraindicated in glucose 6-phosphate dehydrogenase deficiency. In cases of chloroquine resistance, the drug which can be used is doxycycline 100 mg BD for 7 days, followed by primaquine, again to prevent relapse. In cases of severe malaria, we have to give IV artesunate 4 doses in a period of 48 hours. At the 0th hour, that is at the time of presentation, at the 12th hour, at the 24th, and at the 48th hour, followed by doxycycline 100 mg BD for 7 days and primaquine or tefenaquine for preventing relapse.